Hello everybody, welcome back. Chris here. Let's take a look at norepinephrine today. We're going to be rolling out norepinephrine as part of our clinical guidelines and treatment protocols to all of our markets within the month. We're simply waiting to get it in from the suppliers and get it distributed out. But prior to that, we need to take a minute and make sure everybody understands what we need to know about norepinephrine. I want you to understand the mechanism of how it works, talk about the indications and contraindications, how it's supplied, how we're going to mix it, how we're going to titrate it, the expectations and rules surrounding the use of Levophed, and the specific protocols that we're going to be making use of this drug. So looking at norepinephrine from a mechanism standpoint, what is it? Norepinephrine, or its trade name Levophed as it's more commonly called, has become very widely used throughout critical care medicine and emergency room medicine for our patients that are hemodynamically unstable and needing some help. So what is norepinephrine? It is a naturally occurring hormone and neurotransmitter that happens in our bodies every day to mediate vasoconstriction, peripheral vascular resistance, and all sorts of things. Now we're going to be giving it as a medication. And our specific goal there is to reproduce the effects of that endogenous hormone, which will make this classification a sympathomimetic drug and mimic the effects of that hormone on the sympathetic nervous system. The overall goal or purpose we're looking for here is an increase in blood pressure or, again, the hemodynamically stability of our patients. So how does it work? Again, we talked about it's naturally occurring in the body. It is an endogenous hormone. So when we give it in the synthetic format as the medication, it's going to do what those hormones do in the body. We're going to stimulate various receptor sites by alpha 1 and alpha 2 and beta 1 and beta 2 adrenergic response. So in order to increase the blood pressure, what are we looking to do? That hormone, when it activates those response systems, creating changes within our parasympathetic system, is going to cause smooth muscle contraction. The arteries and veins equally are going to cause vasoconstriction. When you have that vasoconstriction, of course, you're going to get a rise in your systemic vascular resistance, yielding an overall raise in your blood pressure. Our beta 1 primary effects, twofold. Number one, a positive chronotropic effect, which is going to increase the speed or the rate of the heart. Number two, the positive inotropic effect is going to create a greater contractile force, a greater squeeze, if you will. That's going to drive up the cardiac output. When we drive up the cardiac output and the systemic vascular resistance, we start seeing an overall increase in our peripheral vascular response. So we're going to start seeing that heart rate go up, the blood pressure go up, and overall cardiac output is going to go up as well. Our MAP, mean arterial pressure, which is what we're going to gauge how well our norepinephrine is working by, you're going to see an increase in your MAP pressure as well. The beta 2 effects, you're going to see those smooth muscle relaxation, have those airway responses, and you're going to get some dilatation of skeletal muscles, coronary artery, and hepatic arteries, which is going to provide volume back to that peripheral system. So basically, we're squeezing the tube of toothpaste in order to create a more rapid and better output of that blood flow. Norepinephrine's kind of become one of the superheroes, like I said, in critical care medicine. It's become such a first-line drug because of those key factors of the alpha 1 creating that vasoconstriction and the beta 1 creating that force and output on the cardiac side, all simultaneously at the same time while you're getting the vasodilatation protecting those other organs. It's become a first-line drug, especially in things such as sepsis, cardiogenic and neurogenic shock. You're going to see it more and more. Our IFT folks are transporting it every day, and our 911 folks, we're going to start using it as a first-line medication for certain patient populations. So what are the indications that we're looking for use of norepinephrine? Hypotension and shock. Again, it's becoming widely used more and more every day. In critical care, it's flowing out to, they're using it on the floors in hospitals. You're seeing it in mobile medicine more and more every day. We're looking for that vasoconstriction. We're looking for the cardiac output change. Again, it's most commonly used with distributive shock. It can be used with any of the shocks as long as it's not that based on hypovolemia or hemorrhage. Now, in cardiogenic shock, it does increase the afterload, which can sometimes work against us by putting that pressure back against the system in certain populations of patients. For instance, those that are in congestive heart failure, things of that nature. So the message is you've got to constantly reassess these patients. You've got to have them on blood pressure monitor, Q5 minutes. Watch that map, Q5 minutes. You've got to make sure that you're also looking at their perfusion status, skin color, temperature, condition. What is the overall shock status of this patient? Sepsis and septic shock, again, it's a distributive shock, widely used in that. Norepinephrine is almost the first line. I know that somebody's going to call me up and say, we used to call Levophed leave them dead. Yes, we did, but we have found out that used a little bit differently, it does help us maintain that MAP goal of around 65, or in that range of 60 to 65. When you see that MAP of 60 to 65, you know you've had that elevation in your systemic vascular resistance and your blood pressure starting to go up. So you're creating a mechanism whereby there is more adequate perfusion to the patient's vital organs and tissues in general. Now, contraindications for norepinephrine: severe hypertension. If you have a hypertensive patient, we're not going to be using it. Hypovolemic or hemorrhagic shock. If the container's leaking, we're not going to use norepinephrine because the vasoconstriction isn't going to do any good. That's a shock where we need to come back, plug up the holes, and work from there. If you have a patient that tells you they're hypersensitive, or they've had norepinephrine before and they've had a sensitive reaction to it or an allergic reaction to it, we're going to use caution. We have to because we don't know. You say, Chris, it's a naturally occurring thing. How could somebody have a hypersensitive reaction to it? Again, that root of the norepinephrine, yes, but we're synthesizing it and putting it in a vehicle of medication to administer it to the patient. And some of those preservatives and additives, they can be harmful to the patient because they can have reactions too. So dosing of norepinephrine. Typically you see a half-life of about 2.5 minutes. Therefore, we're going to do it in a continuous IV infusion. Now, our preference is always going to be to use a central line. Obviously, our 911 folks know we're not going to put in central lines. Our IFT folks, if you've got a long-distance transport ahead of you and there's not one, you may want to talk to the staff about the possibility of a central line. You can use a peripheral line. We want to make sure that we use a larger vein such as antecubital, something of that nature, with at least an 18 gauge or better. You need a good pathway of flow for norepinephrine infusions to make sure that they're working. You'll see these pre-mixed 4 milligrams, 8 milligrams, 16, 32, and 250, or we'll manually prepare them. We're typically going to be drawing it up and mixing our own for now. Again, a lot of this will be based on how we can get it most readily at the time, and we'll keep staff advised on how we're putting those out. Dosing, we're going to be looking at between 2 and 30 mics per minute, and we always want to start those off somewhere typically between 5 and 10 mics per minute, and we will titrate to a MAP of around 65, 60 to 65. It's going to be supplied in 4 milligrams in a 4 milliliter vial, so that gives you 1 milligram per milliliter. Again, read your labels on all your medications. Make sure it is what it is, because there are times in today's supply chain world that we have to use a different concentration, or we have to use a different size vial, or move to a pre-mix when we're used to using vials. Just make sure you read everything before you give it. And anytime we see a big change in something like that, we'll try to get out email messages and notices to our paramedics. So where are we going to use norepinephrine? Hypertension protocol. Again, at that 2 to 30 mics per minute. For hypotension in ROSC, we want to get that patient back up to a optimal hemodynamic state, 2 to 30 mics again. You can sometimes see it used in overdose and toxic ingestions if it's specific to beta blockers or calcium channel blockers. It's rare, but there are some physicians out there that may ask you to use it in that arena. It's in your protocol book for that, but you need to make sure that that is what the ingestion was. Again, all these we're looking for a titrated map of a minimum of 60. 60 to 65 is our optimal range. So we're going to make sure you've got the charts right there in your protocols. You know, you get busy, you're in a hurry, you don't have time to do a lot of math. We've got the drip chart here. So we're going to mix 4 milligrams in a 250 cc bag of normal saline. Making sure we use a dial flow for our 901 folks. Any transport with Levofed an hour or better needs to be on a continuous IV pump. All right, that's mainly for our IFT markets. And I know that some of our 911 folks are right there at that hour mark. Use common sense. If you have a long distance transport, we want it on a pump. All right, so it tells you up here if you're using a 10 drop set, 15, whatever the case may be, it's got it right here for you. So 4 milligrams in 4 milliliters gives you 4 milligrams per milliliter. So keep that in mind. Refer to your chart when you need it. It's there for your use. It's safer. Keep that in mind. Again, IFT markets are rules. Transport over an hour needs to have an IV pump. Preference for that central line if you're doing a long distance transfer. That'll be a discussion between the referring or receiving physician and you at the time of transport if you feel like it needs. 911 markets, you got to use a dial flow. That's not an option. If you're going to use norepinephrine, it needs to be on a dial flow. And keep in mind, either markets, if you're initiating this, we need to be using a larger bore IV and a larger site, such as the antecubital. Dial flow is just a extra extension set, if you will, that goes in your IV line that has the control here to control how many drops per minute you're giving to help you better solidify that we are giving the proper dose as we're titrating up or down. Adverse effects. Most common adverse effects is excessive vasoconstriction. Again, if we get too much vasoconstriction, we can see end organ perfusion get affected poorly. It causes kidney issues, especially if people are already renal patients, things of this nature. That's why you want to make sure you get a good history. Make sure you're monitoring that patient all the time. It can cause tachycardias. It can cause arrhythmias. And let's make sure that we're checking our IV sites prior to starting the drip, because if you get IV, if it blows or extravasates, you're going to get some tissue necrosis if it goes unrecognized. Keep in mind, sometimes there's still a lot of documentation out there that we're not super sure what happens or what the effect is it surrounds pulmonary hypertension. So you've got to look at not just the perfusion status, but the respiratory status. And anytime you're using a medication with the abilities and properties of something like a norepinephrine, you've got to make sure that we're constantly monitoring those patients at all times. So in summary, make sure you've got the right medicine, you're mixing it properly. Make sure that you're doing a good assessment to ensure that the hypotension that you're seeing or the shock in your patient is not related to a hypovolemia or hemorrhage. We want to always try that fluid bolus first. Again, anytime we're transporting, whether we're initiating or transporting Levofed, it needs to be either on a dial flow or IV pump specific to your transport times. Our target for titration is a map of 60 to 65. If you don't know or you can't remember, look it up in the protocol book or ask somebody. If especially in our IFT markets, if you feel like that levofed's running at a really high dose or a really low dose, check with that nurse or that sending physician. They may be trying to do more than one thing with it, or they may have it set that way as it relates to another drip you have. So take that time to ask questions and know what you're up against with medications like this. And when in doubt whether you should use it or not, you can always contact MCP. Again, as always, if you have any questions, contact your supervisor, your market manager, or reach out to me, and we'll get you whatever information you need. So it's our goal that you take these tools and provide the best care we can to all Thorne patients and any of the patients that you service on a daily basis. Again, if you have any questions, let us know. Thank you.